the way I'm approaching this discussion, I think, is from a slightly different place, and it really starts to think in terms of what assumptions we make about healthcare in general. So it's pretty high level and strategic. It clearly lacks the granularity which one would get from a detailed review of workforce and what's required in essence to actually plan workforce. So I think that needs to be clear. However, I think unless we do that, we run into some difficulty in terms of planning for something which may actually not happen in quite the way we think it will. And I'm just asking some really quite fundamental questions here around the business model. We always think we're going through a whirlwind of change in our health and care system. And I would suggest that it's not quite as much of a whirlwind as we think it is. So really I'm asking some questions around the business model. And what the fundamental differences between then and now are, and what's actually happening at the moment, and the speed it's happening at. So the whole basis of healthcare is the office call, the assumption that a patient comes to see a clinician, and we already have it within the word, a patient, somebody who is a supplicant, comes to a clinician, somebody who imparts knowledge. And that happens for a period of time in a day, often a few minutes. And there are a series of communications in a year in non-communicable diseases, say, an hour and a half in a year. And the assumption is that the individual on the other end of that consultation ends up carrying out the instructions for the other 364 days and 18 hours that are left in that year. And I would suggest that is perhaps not quite as obvious and doesn't quite happen in as much detail as we think it does. And if we think of primary care, my father was a general practitioner, and his business model was really not that dissimilar to the business model which I adopted as a general practitioner. Okay, he didn't have a computer. He actually wrote things down. He had a contemporaneous record. He kept a record of people's diseases. He didn't quite have a record of illnesses whereby he couldn't proactively call his asthma patients back on a regular basis and chase the ones who didn't come in quite the same way we started to do. But in essence, the system hasn't quite changed as much as we think it has. And also in terms of hospital, have they really changed? I think the change there has probably been more dramatic. And I think hospitals come in for a pretty hard time from a whole host of us, because people think they spend money they're difficult, there's all sorts of difficulties associated. But I think they've really got a difficult time, because when I was a houseman, in essence, what you did when somebody was admitted in the middle of the night is you kept them warm, you made sure they were safe, you made sure they were hydrated, and you basically had to play around with about 10 drugs, because that's all we had. And it's not that long, I'm not that old, it's not that long ago. While now there are a whole series of pathways you have to go through, which are of increasing complexity, and a whole process of transfer of a patient from another. So in many cases, the life of the clinician in a hospital is now basically a life of accepting a new patient from the previous team and handing over a patient to the next team. And in essence, they don't really care for the people, because they spend most of their time accepting and sending on to the next team because of the way medicine has developed. So I think there are some real issues there. The system is more of something always better. The example I use always is Norway. Norway is an extraordinary place. It is the place which has the highest, we think is the US, per capita spend in healthcare in the world. And probably some of the worst patient safety, the worst continuity of care, the most chaos, because what they have is an epidemic of pilotitis, an absolute epidemic of systems being put over systems, and because they have enough money, they don't stop something, they just add on to others. And you end up with an even more complex service where you need navigators to navigate for the navigators, for the individuals. The whole thing is untenable. And the metrics. We keep on talking about STPs, accountable care systems, which encompasses accountable care organizations. And really, there is a fundamental question here. All the systems we have within our National Health Service drives activity. The metrics are purely activity-based. So talking about a capitated system and a population health dimension and also an accountable care system really starts to ask quite a few questions in terms of what you actually mean by accountable care. And what do you actually mean in terms of accountable? Who are they accountable to? The local population, the system, the provider? So there's quite a few questions I think we need to ask regarding that. But I think perhaps we'll come back to that later. So how has the system changed over the past 15, 20 years? Evidence-based care, the great evidence-based care was something which drove health and care really at the end of the 20th century, where one size fits all diabetics had to be treated, and I think we're really starting to move now to one size fits one. The personalized precision type approach is really going to start overtaking us, and with that comes some real challenges, and those challenges are to business models around pharma, to our ability to be able to cope with such complexity. So this is really quite difficult. We need clearly to move away from medicine by body part. It is not unusual if you're in your 70s to have 4 or 5 long-term conditions. And it is not unusual for you to have to try to follow 4 to 5 different care pathways. Now, if you're not demented at the end of that process, you probably are demented because you should be demented, because actually they often contradict each other. And we don't actually make it easier for the individual because our levels of communication are really poor. And we know the number of people who have difficulty actually managing this process in terms of the people who actually receive it, the patients, is very, very significant. The time of medicine by body part inevitably will come to an end, even though we're getting more and more and more and more specialized at the moment. And the move from patient to person will really start to accelerate. We also know that the biomedical components, in other words, the thing we think are most important, the health bits, are really only a small percentage of what constitutes value for people. No more than 20%. Very interesting research from the University of Wisconsin shows it's as much as 20, but I think people now assume it's more like 15%, with the other percentages being taken on by things which are as important, at least a place to live, something meaningful to do in your life, like work, not being socially isolated, healthy behaviors, smoking, alcohol, decent water, decent buildings. All that stuff is actually quite important, and of course air quality, which I did mention. The digital revolution, it really has changed things because Dr. Google is real now. People go to their clinicians with something they've looked up, and the implications of that are quite significant because knowledge was the basis of how you trained a physician in the old days. You had to remember all the causes of a condition. You had to know all the dependencies. Now information is available to everybody. And really, that is really changing the nature of the relationship between the person and the person who looks after them. So that is changing. Plus also the way we think of a digital revolution. In England, for example, we think of digital as being really useful because with digital we can reform a health system, we can make the business process even more efficient than it is at the moment, and we can replace some paper-based systems with computerized systems. Well, that's fine. I'm sure that's indeed the case, but I think we miss out on one really quite important bit. Why do digital unless you're doing it for a reason? And I think because of everything else that's happening, digital now needs to be thought of more in terms of encouraging and enhancing behavioral change of the individual, because unless the individual starts taking responsibility for their own health and everything else, it's extremely unlikely that any health system, however well funded, will ever be able to manage that. So, health system reform, from commissioning for activity to commissioning for value. And I mentioned already value. What does value mean? Value for whom? Value for the system, value for the providers. What's the unit of currency here? Is it the person? Is it the system? Is it the insurer? Is it the provider? Because depending on that response, the metrics which drive it will be fundamentally different. And I think the other thing which is really, really relevant is the confluence of a lot of the health reforms which have been taking place, as well as the consumer revolution, because they're coming together. And I think this is really quite interesting, because if you look at the triple aim, the famous triple aim from the Institute of Health, you talk about population health, improving cost, and improving patient experience. And if we look at the consumer revolution, which has taken place in all our supermarkets and, you know, everywhere over the last 30 or 40 years, we talk about convenience, cost, and access. You know, the two are not that different. And actually, most people are starting to treat and think of healthcare as a consumer, something which they think in terms of accessing it like they do when they access a banking service, book an airline, or actually think of it as a consumer service. And I think we start to need to understand that. Having said that, there are some intangibles here. People tend to do that with long-term conditions and with chronic care. In acute situations, people at the moment immediately revert to a far more traditional way in which they relate to healthcare. And I'm sure I would do the same if I had a sudden deterioration of health. I really wouldn't be particularly interested in any of this. I just want care, and care quickly, and good quality care quickly. So, will what we have now work in the future? And I think that's the first and important question. About 15 years ago, I was involved in a project which tried, this was in Canada, the oil sands were just discovered. And in places in Canada, they had real difficulty in getting the medical workforce in place, because clearly towns were appearing where 4 weeks before there was nothing other than virgin forest. There was no infrastructure. And really the challenge was to try to devise a digital health system. It was impossible to actually put practitioners in there. And that made me start to think around is it possible that we will be in a situation not that far in the future where the health system will be used far less than it is now? And I think it's not only possible, but it's actually likely. We're already starting to see that already. Certainly in England, in some places where it's becoming more and more impossible to actually get traditional primary care in its old incarnation. And by old, I mean, 10 years ago, primary care of 10 years ago, to actually be organized, because there are no personnel there. And will we really create accountable care systems? Will we really get local government involved, for example, and the people involved, and that accountability and that self-care as we need to? And I think on these answers and on our understanding of this process will be how well the systems which will be able to deliver workforce much more effectively, and the modelling which comes out of that should be based. And I think in terms of workforce, we need a different type of workforce, because the people who would be best to actually assist individuals and citizens in this process are people who would be more like a companion. I'm not sure about a navigator, because hopefully we will have cracked the navigator bit by then. But certainly people will still need help, advice and wisdom around some complexities of diagnosis. However efficient machine learning and all the other artificial intelligence, etc. are, I think we will always need an element of human intervention. But I think we need to start thinking in terms of having a health system that is certainly more agile, more adept, and perhaps starts thinking in terms of health system as a cost center, not a revenue center. At the moment, we think of health as a revenue center. Certainly, hospitals are built as revenue centers. So we need to think very, 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 very differently about the way workforce will develop, because unless we do that, it's extremely unlikely that we're going to be able to design a system which is going to create anything other than a solution for today, which will be put into the context of tomorrow, which will look rather different to what we have at the moment.